Cancer, once a taboo topic, has transformed into a condition that can be effectively managed and even cured, particularly when detected early. The approach to cancer treatment has shifted towards preserving organs and enhancing the quality of life. Recent breakthroughs in cancer care have resulted in the possibility of living a longer, higher quality life for many individuals. Through the integration of cutting-edge technologies within the realm of precision medicine, such as targeted therapy, immunotherapy, minimally invasive surgeries and robotics, not only are more personalized and efficient cancer treatments attainable, but patients also experience faster recovery times and prolonged survival rates with improved overall well-being. The primary goal of oncology now revolves around treating challenging cancers as chronic conditions, with a key emphasis on minimizing disruptions to patients' quality of life and daily routines. Today, let's explore the remarkable advancements in cancer care in India and gain insight into the diverse treatment options available to patients. We have with us two prominent oncologists who are at the forefront of change in cancer care, Dr. Haribhakti and Dr. T. Raja. Welcome to the show. Well, Dr. Haribhakti, let me start with you. You know, the cornerstone of cancer treatment is preventive therapy, early detection. What does one mean by early screening and how important is it?
So I want to make a quick distinction between screening and prevention. Screening is what you do to a patient who has no apparent disease, no complaints. So literally any member of the population is screened. And if you detect something, that is known as a screen-detected cancer. Whereas early diagnosis is different in that you actually seek out a cancer and you are able to diagnose it. Now, prevention is something quite apart, because in prevention, you know the risk factors and you try to modify risk factors in a patient so as to minimize the possibility of the cancer ever developing. To give you a very quick example, because this is known to everybody in the world, Angelina Jolie was tested with the BRCA1 and 2 gene tests, and she was found to have a lifetime risk of more than 80%. And therefore, she went ahead and had a double mastectomy with a reconstruction. So this is prevention, where there is no evidence of disease, there are risk factors, and you modify them to prevent the disease. Now, in our country, the practical aspect of prevention can be in the form of tobacco control. I mean, that's the one major cause of cancer in our country. The commonest cancer in males is mouth cancer, throat cancer, lung cancer. All of them are tobacco related. So that is the one intervention that can take away 50% of all our cancers.
Okay, well, point well said. You've recently written a book, with regards to breast cancer as well, and there you've spoken about early screening, prevention when it comes to breast cancer. Tell us more about it.
Yeah, so let me show you. This is actually the book, and we called it Being Breast Aware, What Every Woman Must Know. All ladies need to understand whether they have any modifiable risk factors. There are two types of risk factors, modifiable and non-modifiable. So the modifiable risk factors are known, and they include things like late marriage, late children, late lactation or no lactation, and the non-modifiable factors are genetic factors, like I just told you, the BRCA1 and 2 antigens. So ladies should know about this, and they should also know that screening is possible, very much possible in breast cancer, and the commonest method for screening is by doing a screening mammography. Mammography is an X-ray of the breast, and what mammography achieves very often is to pick up a cancer before it is at all clinically apparent. So before the woman can feel it, sense it, before any doctor examining can feel it or sense it, it gets detected on a mammogram.
Dr. Raja, I want to come to you with regards to the next question. The key question about early screening is that there are only few tests for men and women. For example, for men, it's the PSA, it's mammograms when it comes to women, and pap smears, and maybe the CA-125 and sonographies, and maybe colonoscopies for both. So in that case, how do you cover other organs of the body which don't come under these tests?
See, what we need to understand is that in India, more than 1.5 million newly diagnosed cancer is detected every year. That's called as the incidence. Out of that, 80% of them unfortunately present at a stage where they are called as advanced stage and they are incurable. But if it is also known, data wise, that if we are able to detect these cancers at an early stage, then again 70 to 80% of them are curable. So you can completely reverse the situation and the outcome in these patients. But then comes the concept of what we call common cancers and screenable cancers. The common cancers are the breast cancer and cervix cancer in women, and prostate cancer in men. And then we have the lung cancer and the oral and head and neck cancer in both the sexes, lung cancer in both the sexes, colon cancers. These common cancers really constitute the bulk of the disease numerically. And if you look at what is screenable cancers, the top 5 to 6 common cancers are known as screenable cancers. For example, these are either surface malignancies or can be detected by a simple test. Breast cancer can be detected by a mammogram, cervix cancer by an examination and pap smear. Similarly, prostate cancer can be detected by a simple digital examination, colon cancer by a colonoscopy, oral and head and neck cancers by a simple examination, and low dose CT for lung cancer. So that's why the common cancer and the big bulk cancer are all screened by these commonly available, well tested methodologies. All
Sure.
other cancers are then decided based on symptomatology. That's how you really rationalize the screening opportunities.
Dr. Haribhakti, you mentioned BRCA 1 and 2. If in case somebody does test positive for it, what is the general advice? Or is it case by case?
No, I think case by case is correct. And I would go further and say that any advice is completely vetted with, with the patient's immediate family, a genetic counselor, and the doctor. I think everybody should be involved. For example, if a woman expresses both BRCA 1 and 2, then the ideal preventive advice would involve not only removal of both the breast but also removal of both the ovaries. So this is a very big decision, and I think we cannot. What I'm trying to say is you cannot treat this as, okay, you've got this, so now you need to do this. It doesn't work like that. There are many sensibilities involved, and I think the implications are huge, as you would imagine. So it's very important that everybody should be on board: a genetic counselor, the clinician, the patient, the family.
Okay. All right. Well, now let's start with, let's discuss the advancements in the treatment of cancer. Dr. Raja, let me start with the diagnosis part of it. How accurate are liquid biopsies for hard to reach tumors?
Oh, they are increasingly becoming popular, and they are becoming increasingly efficient, I would say. We are using it in two settings. One is in the primary diagnosis setting where there is a newly diagnosed patient or where there is a strong suspicion of patient wherein a tissue pathology is not yet established in a difficult to reach site, and that's a very challenging subset of patients, but those patients are now are also there, and wherein I would say that 70 to 80% chance that you will be able to demonstrate the possibility of a malignancy in them. But liquid biopsies are being increasingly used in the secondary diagnosis setting where there is already a diagnosis of cancer, and then you want to longitudinally monitor them for the changes
Yeah.
in the DNA profile, or for the follow-up, or for early detection of the recurrence, or in response assessment. In both the contexts, liquid biopsies are becoming more and more useful, and they are becoming as good as what we call as solid biopsies. Sometimes they are more versatile and more useful than solid biopsies.
Okay. All right. And what about traditional therapies such as chemotherapy, radiation? Have all of these advanced? Have side effects reduced, Dr. Raja? Is it less invasive? And is it applicable to all cancers as well?
Absolutely. Over the past 2 decades, apart from the various improvements that we saw in the cancer care, the best thing that has happened is to improve the quality of life. As regards to chemotherapy, now the drugs have become more and more sophisticated, and we increasingly use what we call as antibodies and conjugated drugs and so on and so forth. And we now have targeted drugs which specifically act on the cancers. And the side effect mitigation, supportive care drugs have improved tremendously. Now we have good drugs to mitigate vomiting and mucositis, diarrhea management, and neutropenia management have all improved tremendously. With regard to radiation, now the technology has improved to be more and more precise. From the days of cobalt and 3D, 3 dimensional radiation techniques, now it has advanced to what we call intensity modulated radiation, image guided radiotherapy techniques, cyberknife tools, and we now have the most advanced proton therapy. The concept is that the radiation is becoming more and more precise, exactly contouring the tumor so that you can avoid the normal tissue and thereby improve the efficacy, dose delivery, and reduce the side effects. Similarly, with regard to surgery also, the minimal access surgeries have become more and more available across the country. The experience and the prolific use has increased tremendously in all centers, including laparoscopics and robotic surgeries have made it possible to operate even in vulnerable individuals, elderly individuals. So these are all
Sure.
tremendous changes that have happened over the past couple of decades.
Okay. Dr. Haribhakti, when it comes to surgical advances in cancer, I want to talk specifically about breast cancer with you. And what are the advancements there? For example, if in case somebody is diagnosed with an invasive cancer, is there any chance of saving the breast in terms of surgery? And what are the advances when it also comes to, say, reconstructive surgery?
Sure. So let me start by telling you that a diagnosis of cancer of the breast, almost more than 80 to 85% of the time, does not mean removal of the breast. Today, and this has been established for the last 30 years all over the world. In fact, a prospective trial from Italy clearly established the safety of breast conservation surgery. So today, a very large proportion of the work we do is breast conservation. Now, in breast conservation also, there is a further refinement over the last 10 years or more called oncoplastic surgery, in which the incisions and the approach is planned in such a way that the breast is practically restored to a normal looking breast. Today, in our follow-ups, very often students find it difficult to tell which is the treated side because the results are so perfect. So I wanted to start with that. Okay. Mastectomy, which is removal of the breast, is required in a minority of patients. Furthermore, if mastectomy is necessary, and there are clear-cut criteria for those who need mastectomy, there is very much possibility of reconstruction, and reconstruction broadly is either implant-based or patient's own tissue-based. It's called autologous tissue-based. So both are very reliable, extremely good with very good outcomes. So today, if you ask me, in practice, for a young individual, when I say young, I mean up to the age of even 50 and 60. And the oldest lady on whom I did a reconstruction was 75. She wanted her form to be preserved. We are able to offer immediate reconstruction.